Welcome to episode 2 of the Michael Rothman, a podcast about mathematical modeling, healthcare, improving outcomes, hospital procedures, saving lives, and many other subjects. I am the Michael Rothman, and let me start out by saying this podcast reflects my opinions and not necessarily those of the company for whom I work, Space Labs Healthcare. So let's start today's episode by continuing the story of sepsis. Sepsis, a major topic in healthcare today, and one for which you will find many articles in the literature. If you look at most of those articles in literature, they will tell you that a third of hospital deaths or 30% of hospital deaths are associated with sepsis. Obviously, a very important subject. But as we talked about last time, yes, although 30% of deaths are associated with sepsis, they are not the primary cause of death of sepsis. In fact, almost all of those deaths are deaths related to a severe additional condition, metastatic cancer, end-stage renal disease, congestive heart failure, and so forth, end-stage kidney disease, COPD. However, it is still a subject worth talking about. And I wanted to get into sort of the ephemeral nature of sepsis today. What am I talking about? The original definitions categorize sepsis into sepsis, severe sepsis, and septic shock. Sepsis was suspicion of infection and 2 SIRS criteria. You can look up SIRS criteria. Severe sepsis is sepsis plus organ failure, and septic shock is severe sepsis plus difficulty in maintaining blood pressure, even with the administration of pressors. These 3 categories are significantly different in terms of their implication. The mortality rate for sepsis is about 5%. For severe sepsis, about 15%, and for septic shock, on the order of 50%. As we've talked about already, sepsis is not a disease. It's a collection of symptoms or conditions, as I've just described. You would think that because it is a collection of symptoms, which you can define, if you just established a rule, you would be able to identify all the patients in your hospital who have sepsis, severe sepsis, or septic shock. Well, turns out that is not so. We did a study with a large hospital on the West Coast. They put together rules to screen for severe sepsis or septic shock. And here is what they found. Of the patients who were identified by the rule as having severe sepsis or septic shock, only 42% of them ended up being coded as having severe sepsis or septic shock. A 58% false positive rate. But on top of that, so you might think, well, you would at least find all of the correct cases of severe sepsis or septic shock. No, they missed a third of all of the cases who were eventually coded as severe sepsis or septic shock. The rule should work, but it doesn't. Why is that? As we've been talking, sepsis is kind of hard to get your hands around. We, as other folks, built a sepsis model to identify patients who were likely to be septic. And we implemented this at a hospital in the Northeast and tried it out. I'm a big believer in testing things. And so we worked with a hospitalist, and this is what we found. Of the sepsis alerts that we generated, a significant percentage of them were septic, according to the definitions. However, the hospitalists treating those patients, in many cases, did not find it appropriate to administer what is called the sepsis bundle, which is IV antibiotics, a bolus of fluid, a culture, and a lactate. Why did she not find it appropriate? Because it wasn't appropriate for that patient. On the other hand, there were cases where she found that even though the patient did not meet the criteria for sepsis, those treatments were appropriate. It is just difficult. And if you focus your efforts on sepsis, you're likely to be disappointed in your main goal, which would be to reduce sepsis mortality. Let me read you something. This is from JAMA and an article from February 23rd of 2016. And I'll give you the citation, but the author is a physician by the name of Edward Abraham. And what he's talking about are the very varied clinical pathways that might get you to a meeting the criteria of severe sepsis or septic shock. And I remind my audience, I'm not a physician. I've worked with physicians and nurses for about 20 years, but I'm not a physician. So if I pronounce some of these things incorrectly, give me a break. So he says, for example, a previously healthy 18-year-old with meningococemia, coagulopathy, and hypoxemia, that's case one. A 45-year-old tourist returning from Southeast Asia with malaria, new onset renal dysfunction, and hyperbilirubemia. And a 90-year-old with a medical history of Alzheimer's disease, diabetes, and congestive heart failure who presents with worsening mental status, decreased urinary output, and a urinary tract infection related to an indwelling bladder catheter will all be categorized as septic and will all have septic shock if they demonstrate an elevated serum lactate level and require vasopressors to maintain blood pressure. The inclusion of such a wide variety of patients with suspected but not necessarily proven infection, organ system dysfunction of multiple types, and a variety of underlying medical condition ensures that even though the new definitions may be helpful in evaluating the epidemiology and economics related to sepsis, they will be limited in their utility to strengthen the design of clinical trials and, most importantly, in directing care for individual patients. So this is what we're dealing with. A wide variety of trajectories that all end up being categorized as septic. So let's talk about what hospitals are doing. And let me start with a presentation that I attended several years ago. I think it was at IHI. And this was a presentation, might have been at HIMSS. I think it was IHI. This was a presentation with the results from a major hospital system in the Northeast. And I was talking to the chief quality officer as this presentation is going on. They were talking about the use of MUSE, which is an acronym for Modified Early Warning System, a popular early warning system that's been around for about 25 years. They were using MUSE and I think maybe some additional criteria to screen for sepsis, and they claimed they had reduced sepsis mortality by 50%. Wow, that is significant. I was impressed, and I said as much to the chief quality officer who was standing next to me, and he said, well, and I said, what do you mean, well? He said, well, it's mostly a denominator effect. And as I thought about it, and as we talked about it, it became clear what he meant. And that is, if you, in good faith, put a lot of emphasis on sepsis, and you put in a sepsis screen, and you're looking very closely at sepsis, you can end up fooling yourself. So here's the situation. Before the screen, before the enhanced surveillance for sepsis, let's say you had 1,000 sepsis cases at your hospital and 200 patients died. This is just a made-up example, not real numbers, but let's say that was the case. 1,000 cases, 200 deaths. What's your sepsis mortality rate? 20%. After the after the implementation of this very carefully engineered sepsis screen, what you find is, in fact, there weren't 1,000 sepsis cases, there were 2,000 sepsis cases. However, the 200 people died, but now you have 200 deaths over 2,000 cases, or a sepsis mortality rate of 10%. It would seem you cut your sepsis mortality by 50%, which would be great, except, in fact, you didn't actually change anything. All you did was widen the pool of patients who were classified as septic. And by the way, hospitals have an incentive for doing this because reimbursements are higher if the patient is septic. So that was an example of a denominator effect where a well-intentioned effort was put in place which had no meaningful impact. Which brings me to one other story which I wanted to tell you. I've worked with folks who are involved with the Surviving Sepsis campaign, and they have been very active in pushing for hospitals to start what is called early goal-directed therapy, which is the sepsis treatment I spoke about, the sepsis bundle, sometimes called the 6-hour bundle, IV antibiotics, a bolus of fluid, lactate, and a culture. And let me interject one thing, and that is there was a large study of hospitals who had implemented early goal-directed therapy. The idea is once the patient is identified as septic, you start treatment within 6 hours. And in fact, CMS has paid so much attention to this that they have mandated reporting on what fraction of your patients who you identify as septic you have started early goal-directed therapy within 6 hours. And if you remember, the timeline comes from what we talked about in my last episode, which is this other widely misunderstood number that there's a 7% increase in mortality with each hour you delay treatment for sepsis. Well, that's not exactly correct. You have to look at the article. I gave the citation in my last episode. But what did they find? They found that early goal-directed therapy did not actually reduce sepsis mortality. And that brings me back to what I was starting to talk about, the Surviving Sepsis campaign, speaking to one of the major physicians involved with it. And I said, to me, the real proof that the Surviving Sepsis campaign is making a difference would be if there was reduction in all-cause mortality. And I asked him, have you seen a reduction in all-cause mortality? Because let's just take the steps as they're out there in the literature. A third of the patients who die, it's associated with sepsis, and sepsis mortality can be cut by 50% using these screens and so forth. So is there reduction in all-cause mortality? No, there was no reduction in all-cause mortality. And it is because this effort to focus on sepsis is largely misguided. As I've investigated this, my conclusions are that physicians generally provide the treatment which is necessary, whether or not you flag a patient as being septic or not. If a patient is in need of fluids, they give fluids. IV antibiotics, they give IV antibiotics. And so these sepsis screens are largely ineffective. And the sepsis coordinators at hospitals are largely frustrated. Sepsis models are largely turned off because it turns out that they are producing signals which are mostly noise. So this brings us to the real question. And that is there anything that you can do to truly reduce sepsis mortality? In the last episode, I promised to tell you why this podcast is called The Michael Rothman. There are a lot of Michael Rothmans out there. I am the Michael Rothman. Why? It's a little bit lighthearted, but it's a reflection of a phenomenon that I've seen as I go to conferences and talk to doctors and nurses. Invariably, someone is going to say to me, they'll look at we're talking about early warning, we're talking about preventing deaths, talking about sepsis. And then they look at my name tag and they say, are you the Michael Rothman? And I say, yes, I am the Michael Rothman. And there are a lot of selfies out there. Folks want to get their picture taken with me, and I'm very flattered. But we are out there in the world of bioinformatics, and it is an honor to be recognized. But we've made contributions to the field. Anyway, so that's why it's called The Michael Rothman. Are you the Michael Rothman? Yes, I am. And as I was saying, to all the other Michael Rothmans out there, well, you may not be but I'm sure you're wonderful Michael Rothmans. In our next episode, we will talk about what you can actually do to reduce sepsis mortality. You can do something. There are things that are appropriate, and there are better uses of hospital resources than are being expended today. And with that, I will say so long for now, and see you next time. Have a great rest of your day. Bye-bye.